Welcome to Swift Coaches Academy, a podcast dedicated to bringing exercise and health professionals the uncensored truth behind what it really takes to succeed in the health industry with me, your host, Zenia Wood. As an accredited exercise physiologist and the founder of Swift Coaches Academy with almost a decade of experience, I'm on a mission to transform the lives of ambitious health professionals who want more and are ready to take action to create incredible impact and financial freedom. So join me as I speak candidly with industry leaders about the struggles and successes from within the trenches through thought-provoking conversations.
Today, we have Zenia's conversation with her first ever technical mentor, Paul Peglar. With 20 years of in the trenches experience, blending musculoskeletal physiotherapy and exercise physiology, he's trained some of Australia's most elite athletes and educated hundreds of exceptional exercise practitioners. This episode is an absolute must as it uncovers Paul's unique approach to exercise rehab and will provide you with the new concepts for programming.
Pegs, Paul Peglar, how are you?
I'm very well, Zenia. How are you? It's been a while since we've spoken.
It has been a while. The last time we spoke, I actually came to your clinic, I remember, for a professional development day. I think it was on...
Shoulder, if I remember.
I was literally about to say on the shoulder, which would have been like pre-2020 for sure.
Oh, yeah, it was pre-COVID. It's so high. It's crazy, this COVID thing. Like time, I've just lost 3 years. 3 years just hasn't existed for some reason.
But before that, we met obviously working together, and you were the draw card, honestly, for me to start at the company that I did contracting, because I was like, there's nowhere else, I've got goosebumps, there's nowhere else that I can get the technical upskilling development from, sitting in for weeks with you of just the way that you can probe people in a really non-threatening but like challenging way, asking why like literally 5 times to the point where I'm questioning myself, even though I thought I was 100% on the concept. I think was really what drew me to work with you and have you as really like my first technical mentor after uni. So
that's lovely. Thank you. I really appreciate it.
No, but it's true.
That's lovely. I appreciate that. Thank you.
It's true. And I think that, you were able to foster a really incredible environment where we were able to, challenge each other in the group and also come up with our own identities around things, but also provide a ton of, I guess, technical knowledge. I'm going to bastardize this if I try. So do you want to give us the rundown of your actual qualifications and then what you do?
Yeah. So my first degree was a degree in London. So I did a BSc honours degree in sports therapy, which the easiest way to think about it is it's like taking the physiotherapy degree, chopping it up, removing what's deemed not necessary for dealing with athletes, and then replacing those gaps with elements of sports psychology, sports nutrition, exercise physiology, sports science. So my first degree, as I said, was an honours degree in that.
Does that still exist?
Yeah, I believe so. I was the third graduate year ever. It was a trial degree that they did in England. And yeah, look, it really attracted me to it. I had a background in sport my whole life. By the time I was 19, I was broken. I was looking for something to do. Physio didn't super excite me because I felt there was elements that I wouldn't use. Nothing against physio, but the pediatrics and the geriatric stuff just never really drew me in. So I'd applied to a sports medicine degree in Glasgow. I'd applied to a whole variety, came across this one. And it was fantastic. And then my second qualification was when I came to Australia and I did my exercise physiology, because the sports science degree, even though it had elements of exercise physiology and sports science in it, it was still a very heavy manual therapy, clinical based degree. And I felt there was huge gaps in programming and exercise prescription. So to kind of round out the whole picture, when I got to Australia, I did my exercise physiology qualification and got my accreditation in that. So I'm a dual accredited holder in sports therapy and in exercise physiology.
With like how many years of practical in the trenches experience now?
Oh, you're making me really old. I think it is 20. Oh, it's 20 years this year.
Ooh,
it's my 20th year. Yeah. See, I actually didn't realize that until you asked me that question. Because then I went, when did I graduate? And I graduated in 2003. I was like, oh, it's 20 years this year.
I hit the first decade next year.
Oh, stop it. Amazing.
So I think what would be helpful to chat about today, probably for a selfish perspective from me in terms of recapping some of the things that I learned from you 8 or so years ago when we first met, but also to give anyone who's listening, I guess, a bit more of an idea around the incredible concepts and systems framework that is your mind in terms of exercise and the phases. I'd love for you to talk through how you program and how you determine what someone needs. Is that enough for you to fly with?
Yeah, absolutely. Look, I think the best thing to work with in this and to kind of put us into a mentality behind where we look at these things is, the human body. It's an interesting thing, and it's nothing but contradictions and conflicts. And so, what we need to recognize is no programming is one size fits all. We need to understand that we need to have a framework or an anchor system that we can bring every person who comes into us back to this systematic approach, so that then we can take that and individualize it to each person. And going back to what you said earlier, which were these lovely words, and this constant idea of questioning, why is, we need to understand that each person is different, and there is no right and wrong answer. There's just better and worse options. So if we work to a very rigid approach, which we get when we look at academic studies, which we 100% have, without an academic study, we don't have the basis by which we can make decisions. But when we work to a very regimented understanding of this is an injury and this is how you treat it, the problem is the person who comes in front of you is nothing but contradictions and variables. So when we look at study and we look at all the research, and research says this, research says this, the problem with the research is, in order for the research to get published and to be determined viable within the industry, we must control every variable except for the variable that we're testing. And then if I can get a result based on that variable, then I can deem my research successful or unsuccessful. The problem is every person who sits in front of you is just an infinite amount of variables. So we need to adapt that understanding that there is no right and wrong. There is no absolute do this or everything else is going to cause problems. We need to recognize that we need to be fluent and we need to be manageable with our patients, and we need to look at them as going, there's a better and there's a worst option. So the goal with this systematic approach is to determine which is the best option for that individual person. So I guess another way of looking at it is at uni we learn the idea behind the objective questioning and objective understanding and objective testing protocols. This is this. Whereas we need to learn to marry the objective and the subjective. So what we don't do a lot of is understanding what the person who comes in tells you. So a lot of the system that I try to develop and that I've worked from and that I teach my guys to work from is probably more from the subjective side as opposed to the objective. Objective is easy. Need to wall is a need to wall is a need to wall with whoever you do it. Your numbers are your numbers are your numbers. They're set guidelines. The subjective is where all the information comes from. So our goal as good clinicians is to be that person who can connect the subjective to the objective. Take the random ramblings of a patient, who are magnificent and brilliant, not as a criticism, but the random ramblings of a patient who comes in and goes, my shoulder hurts here when I kind of do this, but I'm not sure what it's like with this. But when I'm in this weird position, this happened. And I can't remember when it happened, but it's kind of been going on for 3 weeks. But then it was gone for a bit, but now it's kind of come back. But actually, now that I mention it, it's 6 months ago. You know what I mean? So, but in that, there's so much information that we can gain towards this subjective program, this framework, what goes on. And then what we need is this link between that subjective ramblings to putting it into the objective scientific study that we've done. So, our objective measures, our testings, our university stuff, which has told us that this equals that. This research tells me if this person's knee to wall, then this is potentially the problem, or if this person's internal rotation at the shoulder is this, or if this Faber's test gives me this, or this draw test, we've got to go, how do we put them together? So the framework that I guess we're talking about there is me trying to put something down where we can go, if they say this, it's guiding me towards this, which probably gives me into the criteria of these objective tests. So I guess the best way that I would say it is I've tried to break down that into this theory of muscle versus movement. So everything we do, and look, we can sound super smart. We can use really big long words and speak Latin and sound super intelligent and really justify our fee because of what we say. But the reality is the body comes down to muscle and movement. If you're dealing in musculoskeletal conditions, problems, injuries, and whatnot, if you get the right muscle moving, so if the right muscle does the right movement, then you strengthen it. Or if you get the right movement happening, then you will engage the right muscle. Like it's not rocket science. It's not difficult. It's very simple. We can make it sound super complicated. And yes, there's big exercises we can use to make ourselves seem very smart. But the reality comes down to that. So what we try to do is we try to take what the patient tells us and these ramblings, let's call them, and try to categorize it going, okay, where's our problem within the muscle and within the movement? And then how do I test for that? So when we talk about muscle, and this is what I teach the guys, when we talk about muscle, we break that down into 3 categories. There's always 3 areas by which we can make these decisions. There is a breakdown, and if we talk purely based on musculoskeletal injuries, not necessarily conditioning and training. So I'm going to focus more on muscular injuries because conditioning and training, as you know as well, is a little bit different in terms of periodized programming. But when we talk about just kind of rehab, let's call it, you break down into 3 categories. You've got agonist-antagonist dysfunction. The quads are too strong, the hamstrings are too weak. Yeah. You have intramuscular weakness, where there is a particular muscle within the complex dynamic movement pattern that's not firing. A very good example of this is at the deep range, at the beginning range of a bench press, when the bar is directly over the chest, anterior delt is your prime mover, the rest become agonists. And as we move through that normal range of a bench press, the prime mover shifts. So goes ant delt and goes pec majors, then eventually comes into, serratus, pec minor, bicep, tricep, and so forth. So intramuscular dysfunction is a muscle that breaks down. There's one muscle within that big movement that's not doing its job properly. And then the third...
Sorry, just to clarify.
No,
you could
absolutely.
almost... Intramuscular could almost be, I guess, classified to make it easier to understand, like a movement breakdown of one of the muscles in a movement. Yeah,
exactly right. Or a particular dysfunction within a particular movement. So I can bench press fine, but I just can't initiate off the chest. Or I squat. I can squat to 90, no problem, but I can't go deeper than 90 because something hurts, or I lose technique. There's a particular, so I guess the easiest way to look at it, the idea behind agonist antagonist is all of the muscles. So if we make it really simple and we look at it from every chest exercise I do creates pain. So pec flies, bench press, front raises, skull crushers, every chest-based exercise I do, I get this one particular pain. So what that tells me is, irrespective of what's happening in that anterior complex of your shoulder, that particular injury happens. So you're going, okay, well, all the movements. So that must mean that all of the muscles responsible for within that movement, there's a dysfunction. So I look at those agonists, antagonists. What are the agonists to these muscles? The intramuscular is more super specific. So I can pec fly without a problem. I can dumbbell front raise without a problem. I can close grip front raise without a problem. But the minute I bench press, with my arm in that particular angle, in that particular position, that's when I get the pain. Then you're sitting there going, okay, whatever the one muscle responsible for that one particular action, that's where the dysfunction is. So tying it back to the, I hate saying the ramblings of our patients, but it makes it simple to understand. That patient walks in and they go, oh, I've been having this ache in my shoulder for ages. It's really random and weird. Like, I can do all of this fine, but the second I do this one movement or the second I get into this position, it just canes and I can't do it. So instantaneously, you're sitting there going, okay, well, if it was a big agonist-antagonist issue, if it was a problem with the anterior complex was too strong or vice versa, you'd be going, every movement would be a problem. But the minute you've told me that it's only one specific thing, your brain's ticking off going, okay, well, there's one thing. What is it about that one particular movement? What is it about that one particular position or that one particular joint angle that could be straining? So straight away, you're kind of connecting this subjective information across to this objective stuff, because you're going, oh, okay, I reckon it could be anterior delt. So while they're talking to you, your brain's ticking, going, okay, I'm going to do a lot of anterior delt testing. I'm going to test it in all of its ranges. I'm going to have a look at it from this position. And then as you keep going through and they're giving you more information, you're like, that sounds not muscular. That sounds this. And, and then the third part of that is the stabilizer stuff. So stabilizers, and we have to recognize that stabilizers sit in their own world in terms of what they do. And I guess it and you'll have known this from past, it frustrates the crap out of me when we write an entire rehab program based on isolating the let's talk rotator cuff, isolating the rotator cuff. Your stabilizers, from a functional point of view, never work how they move. So I can isolate external rotators and I can do banded external rotation from now until the cows come home. Because the problem with stabilizers is their primary role is to stabilize a joint, not to move it. Yeah. So if I'm doing a shoulder action, whatever it may be, an overhead press, a bench press, a bent over row, prone row, whatever it may be, those rotator cuff will create twitch responses and twitch reactions in relation to the position of the humeral head to make sure it stays in the socket. So you're never going to get full external rotation of a infraspinatus. You're never going to get full internal rotation of subscap when I'm doing a big movement. What you will get is you will get partial contractions.
So, and co-contractions of either side.
Absolutely.
Yeah.
100%.
I get frustrated with this all the time when it's like, oh, my physio prescribed me shoulder external rotations. And then firstly, they're doing it with a TheraBand. So you're like, well, it's hardest at your weakest position. So that's fucked.
Yes.
And then, and then
100%.
even if we give you a cable, I actually don't think that's the best option. You probably need to do some overhead work that's actually challenging the function of the stabilizers.
Yeah, and this is exactly right. And I think one of the biggest problems I have on that, and you make a really good point with co-contraction, and it's about how they work and how they fire, and you have to challenge their function. So yes, absolutely. If I've done a rotator cuff tear, then I need to teach it to engage again. So some degree of rotational work is needed. But if I do 6 weeks of banded rotators, external rotation, I'll become really good at external rotation. But the moment I go back to normal training, I'm fucked, because I have no learned capacity to reintegrate that movement within a big complex dynamic action. So I'm as unstable in that position as I was when I first injured it. And that's what we need to realize. Like the stabilizer's job is to maintain joint alignment is probably the best way to look at it. So when and we won't go into biomechanics. Biomechanics is fucking boring, and none of us like doing it at uni. People who are watching this who love biomechanics, I'm sorry, but it's all about force distribution and even force distribution. We want to keep the joint in its optimal alignment to make sure that as we create force across that joint, we're not going to injure it and we're most efficient. We've got the minimum amount of wasted energy for the maximum amount of effort without the risk of injury. That's what my stabilizers do. They will continuously contract to oppose the big force movement, the big agonist muscles, to make sure that nothing happens. By isolating them into a specific training program, we're doing a great job by using them, but we're doing nothing functionally. So we got to look at them as a separate entity. So then going back to what these subjective people talk about and our patients are talking about is, you know, what's the information they're telling us. So there's kind of guidelines you can see. So with stabilizers, as an example, you will generally find that with stabilizers, it hurts irrespective. So it's the kind of, how would I put it? The randomness of the information, which actually tells me loads. So your patient comes in and they go, my shoulder hurts anteriorly all the time. And you're going, well, tell me what you mean. It's going, every time I train, I haven't done upper body for 3 weeks because I do shoulder press, I do push-ups, I do bent over rows. Just every time I put my shoulder above the horizontal, it just hurts. And you're kind of going, okay, well, that doesn't make sense from an agonist antagonist, because in both push-pull, it's hurting. You know, if the pec is too strong and the pos delta is too weak, in push it should hurt, but in pull it shouldn't be too bad. You know what I mean? And the fact that there's multiple movements across multiple planes tells me that it's not going to be intramuscular because of the multiple nature. You know, when that muscle is not being used, it's not going to affect that joint. So it shouldn't really cause a problem. So that's instantaneously telling you, going, okay, well, if it's hurting across multiple planes in multiple movements, what's the common denominator that's going to protect that? And that's where the stabilizer comes into it. You're going, well, the stabilizer works in multiple planes to maintain that joint alignment. So your brain's instantaneously going, okay, a lot of that information is telling me something. Interestingly enough, pain increases the least I do. So people will turn around all the time going, do you know what? My knee feels fine when I'm up and walking around and when I'm doing stuff. And it feels actually pretty good after I train. But when I get home at night and I sit in the couch, after about 20 minutes of just sitting there, my knee aches, you know, and then you're sitting there going, well, it's not going to be a movement-based problem. It's going to be not going to be an agonist, antagonist, intramuscular, big muscle contraction problem, because they're not doing anything. So what could it be? So the only things that are kind of under some form of neurological tension in those positions are your stabilizers, because you still got gravity, you've still got everything else applying on the joint. So you're kind of going, okay, I'm starting to see a pattern now. Multiple planes, multi-directional actions, at rest, which is when the stabilizer are the only things working, and this consistency of discomfort. So they're like, yeah, look, it doesn't go away no matter what I do. No matter how much I roll, no matter how much I stretch, no matter how much I do these exercises, the pain is always this constant 5, 6 out of 10. So you know what I mean? And to the average person, they just seems like random information, but you can start seeing pattern. And that's the most important thing by, I guess, what we're talking about, by understanding that, and we'll go into the movements in a second, by understanding those muscles and what they do and their roles, you can then take that subjective information you're getting from the patient going, I reckon the problem is your rotator cuff. Yeah, I reckon it's infraspinatus, just to pick a number. And you go, okay, so when I'm going to do my objective testing, I'm going to put particularly the infraspinatus under pressure to see how it manages. And I will do some kind of zero testing as well. I'll do some stuff that hasn't got it under any pressure at all. Mm-hmm. And what you're going to find is you're going to get this scenario where you're like, I reckon your infraspinatus is the problem. And my objective testing is going to test infra and stress the crap out of that, test that hypothesis, and also put it under no pressure. And what you'll start finding is, if you're right and your hypothesis is correct, you're going, yeah, all these tests have proved I'm right. And all of these tests have also proved I'm right, because it doesn't feel anything at all. And
so to give us an example of how you test infraspinatus, obviously being a stabilizer, are you testing it in isolation, or like how are you, give us some examples.
Yeah, so you'll test, what you've got to do is, and this is where we go into the objective testing, where you're sitting there going, okay, well, we got to go through our checklist. So we've got to look at passive movement, active movement, resistive movement, special tests, and then complex dynamic. Now, the rotator cuff, you'll always focus a bit more on that complex dynamic, because that's how it works. So you'll get them to move. Okay, show me external rotation at the side. Show me external rotation at 90 degrees. I always test at 90 degrees as opposed to by the side, because that's really stressful. This is easy to hold it in my joint as put under much pressure. but it's good to have comparisons. And then you will do it passively and see if there's any resistance at all. You're like, actually, it's better passive than active. And then resistive, which will really challenge them at 90 degrees. And you go, okay, I drop out. And you're looking for, good techniques. So you're looking for joint alignment. Can I maintain that joint alignment because my brain is going towards stabilizer? I should be able to maintain it. If you start seeing them doing workarounds, which you'll see all the time. So you're testing at 90 degrees and you're testing their external rotation. They're starting to try to put that joint into a position that they can use it easier. Your body will always go into, like, we call it that fetal position. It's going to try to pull everything. Exactly. So you're going, okay, every time I test that external rotation, it resisted, the body cheats. It tries to go fetal position, shoulder forward, bring it all into the center line. You're like, okay, well, it's not working there. And then you will go, and then you'll test it. So that's active, passive, resistive. And then any special test, you're like, oh, okay, well, if the rotator cuff is cactus, then you're putting your labrals at risk. So I'm going to test them to make sure that I'm not dealing with two problems, cause and symptom. The symptom is the fact that the labral is angry and that's where the pain's coming from. The cause is because your rotator cuff is cactus. So you're kind of special testing gives you that cause versus symptom kind of thing. So your special tests, in this case, you do your labrals and you're like, oh, my labrals are fine. So you're like, okay, it's 100% infra tendon strain. Whereas you're like, oh, labral test is super positive. So you're like, okay, your pain is coming from your labrum because your humeral head is anteriorly displacing and probably affecting it, but your cause is coming from the rotator cuff. And the reason why the special tests are important is, again, to that cause and effect. When we get these muscular breakdowns, it boils down to the fact of this bad force distribution through the joints. It just irritates the crap out of bigger structures, labrums, meniscus, ligaments, tendon attachments, so forth. So your injury could be, let's say, a labral problem. Your cause could be a rotator cuff problem. The issue is you got to settle the labrum before you can get to the cause. So it just starts directing how I select my exercises, which we'll talk about in a second.
In terms of the special test, though,
yeah,
because there's obviously been a lot of research more recently that's like special tests are bullshit, or like, they're not 100%. Very specific or sensitive at all. Do you find that statement is more applicable to muscles rather than like labrum meniscus? Is that
100%? Okay. Absolutely. From my personal experience doing this, I put way more weight from a cause point of view, from a musculoskeletal injury point of view, in the active, passive, resistive, and functional testing. Mm-hmm. So I will take more out of a program design from, let's say, functional testing, from you being able to do an overhead press or a bent over row or a big compound movement than I will out of doing an isolative special test. Mm-hmm. Because it tells me way more about the relationship of the muscles and how they're contracting in line with the joint. And pain is great. Pain tells me lots, but I'm more focused on the technique of the movement, because it's the cheats that tell me the problem, not the actual kind of information that the patients give me in terms of pain. Pain is important because we know when pain comes on, at what point, and what our angles and what our ranges, but I'm more interested on how they've cheated. Have they, if we're looking at, let's say, supraspinatus, are they engaging upper trap significantly more above the horizontal? Because I feel supraspinatus is the issue because I can't set the humerus up into the socket, so I'm using trap to cheat. Mm-hmm. It's the compound movement. It's that big functional movement that gives you way more in terms of determining your direction of programming than the special test. I do the special test because I like to know that there's no kind of specific structural problems that we may need to look at. Because the problem is labrum's a good one. Like, most people have labral problems. If you've played sport from the age of 10 consistently, not at elite level, but consistently and competitively until you're in your mid-20s, I will guarantee you, and I don't have data to back this up, just objective.
Just Pegs will pay you money if you have someone.
That's
just
right.
Chuck $100 down for anyone who comes
just
to him.
done. I will guarantee you, if I scan you if I do a shoulder MRI, you will have labral degeneration or a labral injury. And it's not a long pain. That's just you rocked up to the clinic. Oh, here's an MRI. Oh, you've got a 12/2 labral tear. Like, if you have done competitive sport for 10, 20 years, you will have strain through those joints because that's what happens. And
that's the whole pain versus pathology thing.
100%. And that's why there's such a movement away from scanning people's lower backs anymore, because we scan them and they come back with 2 bulging discs and we lose our shit.
They're terrified of movement.
Yeah, and we lose our shit because they've got bulging discs. They've probably had it for 10 years. Like, a perfect example is patients that come in with severe lower back pain. They get scanned and they come back with a spondylolisthesis or spondylosis, and they're like, oh, you have spondylolisthesis, you're microfractured in your vertebrae and it's fucked. And they're like, oh my God, holy shit, no. And they're 34 years of age and they probably developed genetically through puberty and they've had it since they were 12.
And they're doing CrossFit and they're still playing footy. And yeah.
But the big problem with that is there is that weak link chain. So if I do have a labral tear, by having this rotator cuff dysfunction, which creates poor force distribution through the joints, there's a higher risk that will load up that labral, and then it will get annoyed and will get irritated, and then suddenly it's the labral that's giving me the pain. With special tests, the biggest problem, the biggest danger with doing special tests is when we use that special test as a means to diagnose our problem and determine our way forward. So what I mean by that is I do a labral test, it turns up positive, I'm like, shit, your labral's the problem, and we send you off to an orthopedic surgeon and we do all this and we minimize loading and blah, 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 blah. Whereas these structures, labrums, meniscus, a lot of ligaments for that matter, they don't spontaneously get injured. They don't just
and they're not the cause of the problem 99% of the time. Exactly.
They're not cause, they're a symptom.
Yeah.
So
we fix the symptom and then you still haven't fixed the root problem.
100%. And so we give them 6 weeks of no exercise and no movement and tell them to rest it, and it feels fucking amazing. And then they go back to the gym and it's shit again. Because you're not addressing core root, you're addressing symptom. And structural stuff is generally symptom. It's like ITB. It really irritates me when I listen to people talk about, oh, I've got ITB syndrome and I need to do this with the ITB, and it's the ITB. ITB is a non-contractile fascial tissue. You don't fucking use it. It doesn't
it's your TFL or your glute, depending on which
that's exactly right.
It doesn't, coming from.
100%. It doesn't fucking spontaneously get tight. Something has caused it too. So stop treating the ITB, deal with what's led to it, and then you go forward. So that's where the danger with special tests comes into it. When I use them as the litmus test to determine the root of the problem, I always use them because I like to determine, because you have to also remember that pain inhibition and movement inhibition are real. The more pain we have, the more the brain is going to prevent you from doing the movements that make me go into pain. So what it's going to do is it's going to shut off the muscles to a certain extent to prevent flexion, extension, whatever it may be. And it will avoid the movement that impacts on, let's say, that labrum, and then you're going to cheat. That's where cheat movements come from. If you have a structural problem that's causing pain, if we don't settle that pain down, you're just always going to be pushing the car with the handbrake on. Like, you're just not going to be moving forward. It doesn't detract from the fact that that's not what I need. That's not the problem. I need to address cause, but in very simple terms, it might mean that I will select slightly easier one-dimensional exercises with limited range and minimal loading to allow that to settle until I go into the big stuff. So I'm almost laying the groundwork for the shit that I want to do later on, which is actually going to fix their problem.
And it's not resting. It's just
not resting.
It's just reducing load or putting it into a safe environment so that we're still
I'm pushing to those points, because we've got to remember is your body's very smart at protecting itself. Generally, you've got about 10 to 15% range of motion after pain comes on. And the longer we leave it non-movement, that range of motion is going to get lower and lower and lower. And that pain is going to come on earlier and earlier and earlier. A perfect example is in the extreme version is in arthritis. You get an arthritic flare up, your knee hurts, you don't do anything. that's now your new range of motion. And then you're just going to get tighter and less and less and less and less. You've got about a 10, 15% range of motion you can push into after pain comes on to maintain normal joint happiness. So, it's about knowing how far I can push you. So I use special tests from that point of view. How far can I push you? What do I need to be aware of? Or is that structure just super shitty that I need to make sure it settles before I get into the crux of what I need to do? So what's my groundwork? What's my, if you like, my rudimentary beginning program? And that's what we recognize. We do special tests and nothing comes up special. You're like, great. The main worrying factors, your ACL's fine, your labrum's fine. To a certain extent, as long as I'm not making you curl up in a corner crying in pain, I can push you a hell of a lot more. I can do a lot more muscle control work than I can if that structure's angry. If that structure's angry, depending on what it is and blood supply and how quick you can get healing factors to settle it, I gotta adjust. So I use special tests not as a diagnosis, but as a means of telling me starting points with programs and how much I can push you. But you're 100% right. It's never rest. The answer is never rest. It's just which direction do we work in? So, the 50% or the first half of that program selection is very much in that side, coming from the subjective. What muscles do I need to work? Do I need to work the entire anterior complex, or do I just need to focus on one particular muscle in that complex? Or do I need to work just the stabilizers? Is that my goal? Because what you're looking to do essentially is get a ratio of exercise. And the ratio of exercise is, let's just pick a program that's got 8 exercises in it, just to make a simple example. If I'm in a agonist-antagonist problem, so your hamstrings are super weak, your quads are super dominant, which is leading to anterior hip pain because your rec fem tendon is shithouse. Of those 8 exercises, 5 of them have to be compound-based exercises. They have to be exercises that are going to challenge the hamstring in all of its movements across all of its planes to build strength. So you've got to be looking at your program and going, am I doing compound-based hamstring work to stress them to form strength? And of the 3 exercises left, because of the hamstrings are shit, the quads are too dominant, I can guarantee you've got a dysfunctional movement pattern, which means how you're loading the joint is going to be out of whack. So you're going to have to retrain the stabilizers to stabilize the joint in its normal range. I mean, and I know you've said this to patients before, but I say to them all the time, your normal is probably about 15 degrees off center. And you see it when you give patients the exercises. You're going, oh, you're off center. I'm going to move you. I'm going to shift you this way, or I'm going to pull your leg back this way, or you got to rotate your hips this way. And you're like, oh, fuck, I feel so off center. You're like, yeah, because you've been stuck this way for so long, your body now thinks that that's normal. And that's what's causing this problem. You're just loading up the joint and you're focusing force loading. So with the compound stuff, of the 3 exercises left, you'll have at least 2 stabilizers to retrain that pattern. And then you might have one isolated single plane exercise that works predominantly on bifem, because that's the one you've decided is the weakest and I need to work predominantly on that. Mm-hmm. Whereas when you start then looking and you go, okay, well, I think your problem is more intramuscular. You're sitting there going, okay, I need to have, of my 8 exercise, 4 to 5 of those exercises need to be more isolated to that muscle. So I need to make sure that, let's say it's your posterior delt. I need to be able to look at my program and go, that exercise works that movement of post delt. That exercise works that movement of post delt. That exercise isolates that movement of post delt. So I'm covering all the extensions, the external rotations, and so forth. So I'm like, yeah, that one's that one, that one's that one, that one's that one, that one's that one. I've hit post delt in all of its planes and all of its movements. Again, because it's an agonist antagonist, it's a big moving muscle, you're probably back into stabilizers to make sure you're re-zeroing the joint. And then it's really important that you've got at least 1, if not 2 compound exercises, because there's no point teaching posterior delt to work if you're not teaching it how it should work in all the rest of them.
Like, integrate it.
Absolutely. Integrate. It's a perfect example. Like, isolated exercises are just useless. It's a pointless situation. because we don't work in isolation. We don't move in isolation. We don't move in single planes. Everything we do, you know, you come into the gym and I do my fucking banded external rotations at the side of my body. And for the rest of the week, that is the only time that muscle and that joint will move like that.
It kills me.
If you're not, I know, if you're not challenging function, you know, it's the same thing. And we see it all the time. People come in, and I fucking love this. And I used to see this in the clinic as well, where people will come in and they're like, oh, you've got a grade 2 hamstring strain. So, you know, everything we're going to do has to be deloaded, non-body weight, you know, lying down, don't put any weight on it. And so they spend 30 minutes or 45 minutes with you, completely non-weight bearing, you know what I mean? Not stressing. And they're like, yeah, it feels great. And then they walk out. And you're like, well, you're just fucking spending your entire time walking around, not on crutches, body weight. Like, why have I done everything non-body weighted when you're going to spend your entire time body weighted? So it's this idea of, yes, we need to isolate stuff. We need to address the movement. We need to be conscious of pain inhibition, movement inhibition, but we've also got to make sure that everything we're doing is progressing function in the person, not just isolate a muscle and work it. You know what I mean? And then with your stabilizer, it's the same mentality. It's the exact same mentality, just the ratios are a bit different. So if you're talking your 8 exercises and I'm working, let's just go down the body and with your hip stabilizers, you may have 3 isolative hip stabilizer exercises. So this exercise stabilizes this or activates this muscle, but you've only got about 3. And then you've got about 4 big compound. Because like we said earlier, unless you're challenging the stabilizer muscles to work in the function to it, you're never going to progress that instability problem. Unless you're going, okay, hey, I want glute mid to work. So I'm going to do this exercise to fire glute mid. But if you're not now getting a corresponding exercise that's going to challenge that activated glute mid muscle to work in this body weight sprinter squat, there's no connect. Your body doesn't, because stabilizers are so contradictory in that term. How they move is not how they work.
Yeah,
so you can
their action is not their
much.
function, and function is their
I
primary
love that.
role.
Yeah, I love that. Their action is not their function. It's exactly right. So you stabilize stuff, going, I'm going to isolate them with these 3 exercises, but then I'm going to have 4 big compound to challenge them. And then I might look at one isolative exercise based on just how they're moving. I don't like how my glute max works at top end extension, so I'll isolate that. You know, but that's where your testing comes into it. That's where you're looking, going, I reckon what you've been telling me earlier is it's a hip stabilizer problem. All of my objective testing is telling me that it is a hip stabilizer problem. And in my objective testing, I've also noticed that you have a proximal hamstring weakness. So I'm going to isolate that. Does that make sense? So the idea that what they're telling you in terms of pain, when the pain comes on, has a big impact in where you focus your objective stuff. And that goes through the board. Your compound is the same. You know, every time I do a chest-based session, I get pain. Every time I do a back pain session, it's actually not too bad. So pain on the contractions. So you're going, okay, these muscles are too tight, but it's every particular movement within that action creates pain. So you're like, okay, well, in that case, it's all of those anterior muscles, which means I need to strengthen all of those posterior muscles to compensate. Mm-hmm. So my program has to match that. And then you'll get stuff like, you know, it's not too bad walking around everyday life, but when I do my chest session, it's really hurt. Pain just walking around at work, sitting at the desk is like a 1-2, it's a bit of a niggle. But the minute I get into chest press, pec flies, and this is the thing with compound, again, it's a multiple movements thing. Bench press, pec flies, front raise. It's those multi-plane engagements. You're like, all those muscles are dominating and creating this problem. So you're like, my pain goes from a 2 to an 8. It's a huge jump up. It's a really low aggravating, high easing situation because there's so much pain. It's like I do a chest session and I'm rooted for 3 days. You know, I mean, how many times you had a patient come in going, oh, I'm not too bad if I do this, but I haven't bench pressed in 6 weeks because every time I do it, shit.
Yeah.
You know what I mean? So that kind of subjective stuff is telling you going, oh, I reckon it's an agonist, and you do your testings and you follow that route through. And then again, like we just talked about, you will confirm going, yes, it is a agonist antagonist problem. And we follow that mostly compound exercises, posterior chain for shoulders. We'll have a few rotator cuff stuff to make sure humeral sits there, and then it's one isolated. And then it's the same with your intramuscular. They'll come in and they'll go, look, it's fine. Like, I have no problems. I see this with CrossFitters all the time. I've got about 7 guys in at the moment who are kind of into semis, looking for games and things like that. And I don't know how, I reckon every single one of them comes in going, I can fucking flog it. Yeah. I can snatch great. My jerks are awesome. My deadlifts are fucking huge. I can double unders, no problems. But the second I do a kipping, I'm rooted. Or the second I go into handstand push-ups, I can't do it. So you're talking about a guy who can fucking do, 100 kilo clean and jerk, but can't do a handstand push-up. And you're like, well, that's where you're going, okay, it's that one, what's going on in that one particular position, that one particular action, that one particular way that the body is using its muscles that's causing this problem. And that's that intramuscular stuff. So you go, okay, you're ticking through the boxes and you're going, okay, could be this muscle, could be this muscle, could be that muscle. Break that down, going, okay, at the and then you're asking, is it at the top of the handstand push-up or is it the bottom of the handstand push-up? And they're like, oh, at the bottom as I'm pushing up. You're okay, what's the muscle response? You know what I mean? And then as they talk to you, you're like, oh, I'm ticking boxes here. It's an intramuscular stuff, and I'm nailing it down to, oh, I reckon it's posterior fibers, mid delt. So then you go, okay, come with me into the gym. We're going to do a whole lot of testing. And you test anterior delt, posterior delt, mid delt. You test all of those. Your mid delt is shit. And you're going, yeah, tick, 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 tick. Special tests, and then you go forward. And then your whole programming is specific to that. So it's that. I guess my approach to a lot of my programming is connecting that subjective questioning to the objective tests we already know. Like, that's fucking the objective stuff. We spent 4 years at uni of them hammering us home. The problem with objective testing, it's all based on case studies and research papers, which have got very little bearing on
Makes it hard.
Real life. 100%.
And so then let's say that using your system, you've figured out which type of problem, if it's a stabilizer, agonist, antagonist, or the intramuscular, as you call them. Talk to me about your next stepping movements and exercises being last, because you're the person who taught me this, and I have it at home, and we had a masterclass on the hip the other day, and people were like, wow, this is such a wild concept. And I was like, what do you mean? Like, this is what you should be doing. Because how do you know that, if you wanted to train the hamstrings eccentrically, but you just put an exercise in your program and then that machine's taken, and then you do like a hamstring curl, but you wanted eccentric load, like, how are you supposed to know that in the moment? So could you explain your movements first, or movements before exsaizes kind of mentality?
Yeah. So I guess the other side, Dave, because as I said, it's like 50-50, 50% muscle, 50% is movement. The way I explain it and the way I look at it is the idea behind movement. So you go all the way back to the way we're born. So the way we're born is, we can't do anything. We just lie there doing nothing. And as we start moving, the body starts learning how to engage muscles. So jumping to the end and explaining it, we move through 3 processes. It's muscle activation, neurodevelopment, strength. So muscle activation is the body's ability to go, oh, that's a quad, and that's a hamstring, and that's a glute. And if I fire that nerve, then that muscle causes the knee to go into extension. So it's a very rudimentary, very simple based, that muscle equals that movement. So by the age of 8 months, 12 months, we've kind of gone from lying to rolling, rolling to crawling, crawling to standing, standing to walking, walking to running. So it's the body's process of going, if I fire this neuron, it creates that response, which creates that movement. So knee extension. So muscle activation is the process behind that. Neurological development is then the process of going, well, if I fire that muscle and that muscle and that muscle in sequence, I get a gait cycle. I get hip extension, knee flexion, plantar flexion for toe off, and then I swipe through. So it's the idea behind the sequence of recruitment for muscle. And then strength, muscle strength is then going, okay, I now know how to fire all those. I apply loading principles to those to make that movement more efficient, more recruitable and stronger. Now, we do this as a child. So you're born, can't do anything, then you roll to crawl to walk to run. But what we have to understand is this process of learning occurs the whole way through. So training experience is a huge impact and has a huge role. If I have, and it's why I'm a big advocate for all kids, once they've hit kind of the age of 8, 9 years of age, doing multiple sports, not just being specific to do football. You know, if I had my way, every single person, male or female, would start with like gymnastics or something like that. So body awareness, upper body, lower body transfer, rock climbing,
all the shit that I waited till I was like 27 to start doing.
Yeah, all of the stuff that, and what it does, and it's actually really interesting. And working with the AFL Footy Club here, it's really interesting to see the shift now, because obviously AFL, there's been a huge growth in the WAFL. The Quaffle team, they're here, great, but it's really interesting to watch the men versus the women play, because athletically there's no difference. Like, men and women can do the same thing, you know, apart from the obvious and the pelvis, there's very little difference, males versus females, musculoskeletal. But you watch their skill acquisition and there's such a difference. Like, you can tell, and we're at this stage now where I'm hoping, and I really think it is, that we're in that last generation of that boys play football, girls play with dolls at home, you know, because we're seeing that in the current senior team. Whereas the blokes, their minimum skill level is here. Whereas the skill level of the girls, it's so varied, and some are great and some are really bad, that you can tell the girls that have played sport since they were under sixes, and you can tell the girls that have played sport later. Do you know what I mean?
Yeah.
And it's a real good experiment and example of this idea behind muscle activation or development strength, how we need to promote this global kind of movement thing that we should be having. Like, it irritates the shit out of me when I hear people talk about, and you use those ills, and I know this drives you mad as well, you kick like a girl, you throw like a girl. Like, being a girl has no impact on your ability to kick or throw. When you're exposed to those movements at a younger age, impacts your ability to do those. You know, you can see the girls that are playing here that have done it since they were under sixes, under eights, and have kind of gone through the ranks of junior AFL, that they're fucking on point and their skill level is as good as any of the blokes. It's the ones that haven't. And that's what we need to learn. So the problem with muscle activation, neurodevelopment, strength, and the idea behind training experience really ties into this in two ways. So the question you've got to ask yourself is twofold. One, has this person has a training history? Have they done things in the past? Have they played sport? They'll have a way better body awareness, way better neurological strengthening. Your ability to progress through their rehab program will be significantly better because their neurological recruitment is going to be better. The other aspect of it as well is the length of time that person has been in pain or injured. Because the longer they've been in pain and injured, the longer they've had dysfunctional movement patterns, the more they've unlearned how they should move, the more you've got to select and you've got to go through the pathways of muscle activation, make sure everything is firing, neurological development, and then strengthen. And one of the shortfalls that we have from a rehab programming side of view is we're really good at going, oh, your issue is a agonist antagonist, your hamstrings are too weak, your quads are too strong. The problem then arises is we give that person the wrong exercise selection. They're either too complex and the body doesn't have the underlying baseline to be able to do the movements, and it creates problems, and then the body goes, I don't know how to do it, and you're always struggling. Or, which I see a lot of, we give them shit that's too fucking easy. and their body is, it's easy for them to do the basic simple rehab exercises, so they never progress because you're not actually challenging them. I mean, I see this all the time, and it amuses me. I deal with a lot of the powerlifters. I've got 5 guys that have been down at Pro Raw. I look at, guys that have got, girls that have got 400, 500 totals, guys that are up in 800 totals, and they come in with a shoulder problem or a bit of pain, anterior pain, There is no TheraBand on this fucking planet strong enough to develop their posterior delt to compensate for the fact that that girl can bench 160 kilos. This is just not going to happen. So I'm giving them these small TheraBand banded exercises, and you're just wasting your time. Their training experience, their muscle activation, neural strength is way beyond that exercise. So they don't progress any further. We're not addressing that. So the idea behind the movement is more about not like flexion extension. It's more about body awareness. Do I have effective muscle activation? Do I know how to engage my quads, my hamstrings, my glutes? Do I have that baseline? And then do I know how to engage them in a coordinated fashion? And then have they strengthened them in the past? Because if they don't, I need to figure out where they sit. So my exercise selection must match their ability to do the exercise. If I've got a 42-year-old accountant who's never trained a day in their life, and they're getting anterior knee pain because they joined CrossFit 8 weeks ago because they did a stress test at work and they're overweight and the doctor says you need to fucking sort your life out, and they join CrossFit, now they're getting anterior knee pain. Yeah. And I'm going, oh, your problem is your glutes and your hamstrings aren't strong enough and your posterior engagement isn't great and you can't sit back in your heels. The problem is you're not using your hips, you're bending at your knees, you're driving your knees forward, and all the loads hinging on your patella tendon, which is irritating it. Me giving that person a pistol squat or even a pendulum squat to rectify neurological functioning is only going to create more problems, because they couldn't do the hip tilt to start with. They didn't have that complex neurological recruitment. Now, yes, absolutely, a sprinter squat to get, lateral hip stability and, a single leg RDL to bring in upper range eccentric control of hamstrings is fucking wonderful. And it is the right exercise to do to help with that problem. The issue is old mate's never done that. So he's never going to be able to do that. So you have to use that movement ability to try to get them to the point that you're prescribing the right complexity of exercise to match, get the right complexity of exercise to match the right kind of muscle development that you need. Does that make sense?
Yeah, I think so. I guess what I'm hearing is the people who are quite low level, don't give them shit that's complex compound movements. They probably need to start a little more isolated. And then the people who are doing shit like 160 kilo bench presses, make sure you're not just giving them a fucking TheraBand external rotation, throw them under some progressive 100%. Load. Is that?
Yeah. and that's it. To be honest with you, that's exactly right. And it's about fucking dumbing it down. There's no, and that's what I mean. It's not rocket science. It's effective, rational, and clinical reasoning behind your exercise selection. That's not rocket science, but it's about knowing it and applying it to how you program. Because the reality is that 42-year-old accountant who's joined CrossFit, at some point, if he's going to continue CrossFit, has to be able to do a partial pistol, a unsupported pendulum squat, and various other single leg things to allow him to have enough medial lateral femoral stability to do what he needs to do. So that guy has got to go to complex dynamic movements. If that guy is still doing fucking basic non-weight bearing isolated VM and glute mid-min exercises after 8 weeks, then you're kind of not progressing him quickly enough. You're not doing your job. But if you're jumping ahead 6 weeks and putting him into these things because you've got patella tendinopathy and we need to do, heavy eccentrics and drop squats, you're just also going to cause problems. And I guess that's the big thing that you got to look at. Just because it's the right exercise doesn't mean it's the right exercise right now. Like
for that person.
Exactly. That idea of experience and movement, muscle activation, neurodevelopment, strength. It's about allowing you to go, this is your problem. You need to do modified Arnie press. That's how we're going to fix whatever your problem is. But I need to start here in a very basic, simple exercise to progress me to get to this. So you're sitting there going, this is what's going to fix you. So I got to have my eye on the prize, and I need to make sure that every exercise I select from here to here gets me to this point, because that's us attacking the cause. But if I jump straight to the end point without this ability to recruit the muscles in a position and in a way that is needed to allow this to happen, then I'm just going to create more issues and more problems. This is why people just get on the treadmill in the cycle of injury. Does that make sense?
It does. I reckon you can talk underwater, but I think we're going to have to.
I was like, shit. I've already like done the whole thing. I've kind of given a taster as to what it's probably like. There's so much more to it.
So quickly, do you have any courses coming up or anywhere that people can learn from you?
Well, I have actually. So what I've done is the course that you've done, I've actually put it onto an LMS program.
Awesome. So tell us about that. Where can we find it?
So we're in, what I'll do is I'll email it through, because we've literally just launched it. So you can go onto our website and it's all on there. It's under the educational department. So the LMS programs are running, so you can just log on. So what we've done is we've started with the knee. So just the knee. And yeah, it's the great thing, because that was the problem. I'm so strapped for time. It was so difficult to get courses running that I really needed to kind of get a way of just getting them out there. So now you can just download it whenever you want. And it's the entire course, plus pictures, plus videos and everything. And it's through that LMS program. So you can just download it and go nuts whenever you want. I'll flick you through all the details. But if you go onto our website,
which is
at starttrainingstafford.com.au.
Perfect. I'll say that a little bit slower and in Australian for those who are listening.
Thank you.
Starttrainingstafford.com.au, and that's the same as your Instagram handle. Yes. I'm so fucking glad to hear that you're you're keeping up with the technology and you're finally online.
I'm so technologically savvy. But yes, so they're ready to go whenever, so people can log on, download them and get them.
Yeah. Amazing. And then the last thing that I love to finish up each episode with is one really succinct take home or actionable item that after listening to today, someone can go and run with their program. If there's just one thing that they could do, what do you think would be the best step forward?
I would say the best thing to do is develop your subjective questioning for your patient, because I find that the subjective questioning tells me more about the program that I'm going to write than the objective measures.
And how do you think people should go about improving their subjective questioning?
Talk to as many people as you can. Question about injuries. What we find and what I've found in 20 years of doing this is everybody says the same thing. They just say it slightly differently. So what you want to do is develop your understanding of clinical reasoning around time. When did it happen? When didn't it happen? Pain level. When's the pain come on? How painful is it? And your movements. When does that pain come on? When I do this movement or that movement. If you start honing your skills around learning that, it opens you up to what I was talking about, going, oh, I reckon your problem is a stabilizer problem. Mm-hmm. And then it will organically, without you having to do anything, guide you into your objective test, which will write your program for you. If you take the time to learn how long the pain's been going on, what causes the pain, and how painful is it, and you learn to question your patients around those components, you suddenly get a whole new understanding of what's happening, and then you can apply it to what I was talking about. And honestly, within days, you'll be starting to relook at how you write programs. Because exercises are exercises. Exercise is the last thing you should ever write in a program. That's the fucking easy stuff.
Which is what people generally, I find, get confused, and they start with exercises and work backwards. But if you have all the other information, the exercises almost just present themselves.
That's 100% right. Exercise is just, it's easy. Like everyone knows exercises. It's what to give is the question.
Yeah. Cool.
Yeah.
I love it. Let's leave it there.
Amazing.
Have a fantastic rest of your day.
Thanks, Zenia. Let me know what's going on. If you need any more, just give us a shout. Thanks,
Perfect.
Zenia.
Thanks.
I'm gonna head into mission. Have a good day.
Bye.
Bye.
If you enjoyed this episode, it'd honestly mean the world to us if you could share it with a friend or on your socials, follow and leave a quick review so that we can bring you more real, raw and uncensored stories from industry leaders. We also love hearing your feedback, so please DM us on Instagram at Swift Coaches Academy if you have suggestions for future guests or topics. Until next time, and in whatever you do, move swiftly.